Good evening. Welcome to the second chronic pain webinar. This one particularly targets the practice and practitioners in practice and how they can use the NICE guidelines for chronic pain to aid their business. So what we would like to do to start with is ask Mark to go with an overview of what the chronic pain guidelines say, the NICE chronic pain guidelines, and then we'll go through the panel and introduce ourselves and give a bit of information on our experience in this field, and then we'll go to questions afterwards. So if that's okay, we'll go over to Mark.
Okay, evening everybody. I'm Mark Bovey, until fairly recently research manager for the British Acupuncture Council. So NICE guidelines have usually been a crashing disappointment for us as acupuncturists, because in the vast majority, we don't even get into the guideline review process, but we get filtered out sort of at the scoping or pre-scoping stage, on the basis of what they think the evidence is. But we do have recommendations for tension, headache and migraine. On the other hand, we don't have recommendation in respect of osteoarthritis. And of course, most particularly, we don't have it now in respect of low back pain, having been endorsed originally, but then in 2016, that got turned round. So this recommendation now in respect of chronic pain is a massive plus for us. A couple of things to note particularly, it's chronic primary pain and it excludes secondary pain. In other words, it only refers to pain where there's no particular underlying condition that explains it, or that there is an underlying condition, but the pain is out of all proportion to what you'd expect. And the examples that NICE give are things like fibromyalgia, myofascial pain, chronic neck or pelvic pain, and complex regional pain syndrome, which happened to be the one I think that there were more questions about than anything else when we had the public webinar last week, that and fibromyalgia. So second thing to note is that it specifically excludes conditions where there's an existing NICE guideline. So it excludes arthritis, it excludes back pain. And so the interesting thing there, as some of the stakeholders in their comments have pointed out, is for someone, for example, with fibromyalgia, where commonly one of the most common areas for pain that you get with fibromyalgia is in the back. So there appears to be conflict there. Is acupuncture then endorsed for treating those people or not? And NICE's reply to that was that it's down to the clinical judgment of the practitioner, which I guess is mostly going to be the GP at the initial stage. So although you might, I'm just, if you just took on board that it was about chronic pain, then you'd think that it would cover all of these things. Then knowing it's only chronic primary pain, you might think, oh, it throws out some of the things which are like the best things that we treat. But it seems in fact that it's kind of can swing either way, or maybe both, even for one person. So that it specifically says that it covers acupuncture that is under either a traditional Chinese medicine framework or a Western medical framework. It doesn't really expand any more on what they might mean. And it allows for up to 5 hours total of acupuncture treatment, and that could be divided up in terms of numbers of sessions and times, however you want it. And most particularly, they're very concerned about the cost implications. And so they say that these 5 hours have got to be delivered by someone who's NHS band 7 or lower, or an equivalent. And they added in the final guideline that they added a bit more leeway there as to who can do it. So they said basically any other equivalent health professional, as long as it's not going to cost more money than an NHS Band 7. So how did we manage to get recommended here, whereas we haven't, for example, with back pain and OA? Well, one thing is there's an acupuncturist on the committee, and that, I'm not sure if that's a first, but it certainly hardly ever happens, and it's obviously a big plus. Secondly, in their evidence review, it just happened to come out that acupuncture was better than usual care and better than sham acupuncture by a sufficient margin for them to say that it is clinically significant. And this was the thing that we got beaten down about in back pain. So it had to get above a threshold of 1.0 on a pain scale, and versus sham. Back pain, it just fell below that. Here it was more like 1.5. So overall, the committee summed up the evidence as saying there was quite a decent amount of evidence from large trials for acupuncture, and also evidence of cost effectiveness. If you look through the stakeholder comments, and there's 1,150 pages of them, so I've only got as far as B in the alphabet, and then had to kind of skip around. The British Medical Association said that they're not convinced by the acupuncture evidence, given what happened with back pain, and so they would like to have seen more research done before it was recommended. And the Royal College of Nursing said something similar. As I said, I've scarcely touched on the whole lot of them, but I imagine there'd be some other. But there was nothing really damning or very hostile against acupuncture. And I think the main issue that those sort of people, doctors, pain specialists, and what have you, have is, how are the non-pharmacological therapies going to be paid for out of NHS budgets? And does it mean that patients are just going to end up getting a whole load of antidepressants, which is the one medication that's allowed now? My nicest reply to this is, you're going to save money on various things that are no longer recommended. So some of this can go into paying for training up people to be able to deliver these other therapies. Okay, I think I shall stop there and hand over to the rest of the panel.
Okay, thank you. So now I'm going to go to each panel member and ask them to introduce themselves and give a little overview of where they've worked in either in chronic pain or within the NHS, or both. And then afterwards, when you do want to ask questions, I'll ask you to raise your hand and you can direct questions at particular individuals on the panel. So can I ask Susan now? I know that she also wants to talk about some of the resources that we have. So Susan, if you go ahead.
Okay, hi, I'm Susan Evans, and I'm a board member, and also I am heading up the Professional Recognition Working Group. So for us as the Professional Recognition Working Group, this is good news because it gives us another tool in our toolkit when we go to health professionals, when we go to government. You know, our PSA accreditation is what we sort of use at the moment to get people to pay attention to us and give us a bit of credibility. And I think having these new nice guidelines now will really help as well. So that's what we're doing. We're actually contacting government and we're contacting health ministers and just trying to get us some more professional recognition. So I think things that every member can do is one of the things that is now on the website is a letter to the GP. So everybody can contact their own GP. They can use this template and they can add to the template, and to contact the GP to just let the GP know that we are available and that they can use us. I think that's a really useful tool, because so many GPs don't recognise, they don't know that we are accredited acupuncturists. And I think just to make ourselves known to them, even if they don't use us immediately, they might at some point use us. There is also a really good PowerPoint, which if you're doing a talk, you might even get invited to GP surgeries to do talks, which are fantastic. I know I've been into my local GP surgery before, pre-COVID, because they have training days, and I went in and spoke to them about acupuncture, which was a very informal conversation, and it was really useful. I can't say I got a lot of referrals from it, but I did get some. And I just think it's that education that we need to go to them and let them know that we are here. And that I think we're going to put on the PowerPoint something about the NICE guidelines, which would be really useful for you to be able to use. And to try and get into GP meetings, I think is a really useful thing if we're able to get them to hear what we have to say. Because, as accredited acupuncturists, they can actually refer patients to us. And a lot of them may not know that. And certainly a lot of our patients don't know that. So I think that would be a really useful thing to do. And my experience, 2007, which is a long time ago now, 2007, 2008, the government here in Northern Ireland ran a pilot project, and we were integrating complementary therapies into the NHS. So I worked in that, and we saw patients with chronic pain. In fact, we got the heart sink patients, the patients that went into the GP every Monday morning with complaints, and they were sent to us. So we saw people with musculoskeletal pain, and we saw people with anxiety and depression. And it was amazing, really, to be able to get those direct referrals from the GPs and see the people. I actually worked in a GP surgery during that time. And I was amazed at how much support there was from the patients and how they turned up. Because I thought, oh, they're not paying for this, they won't turn up. But actually, they really, really turned up. And as they started to improve, they got the benefit of the treatments. And even one of the GPs went off and did acupuncture training halfway through the project that we ran, which, all right, it was BMAS training, but he thought that the acupuncture was so useful. And it was just really good to get that credibility through the GP surgeries. And I think the more we can do that sort of drip effect getting in there, the more people will actually start referring to us. So I think that's my little bit explained.
That's brilliant. Thank you very much, Susan. We'll probably come back to you, and if anybody has some questions for you later.
Sure.
So I'm going to go to Paul now, Paul BAcC. If you'd like, I'm not doing this any preference order. I'm doing it because that's the next person on my screen. So go ahead, Paul, please.
Good evening, everyone. I am Paul BAcC. I'm a practitioner in North West Kent. I sit on the governing board and chair the Professional Standards and Regulatory Committee. It's interesting. I'm really pleased that NICE have kind of produced this document that kind of demonstrates that acupuncture is effective. And when I was asked to kind of sit on this sort of panel to talk about what I've done or how you can use kind of the documentation that's there, how you might benefit from it. I'm a local practitioner, so I practice and work locally. When I left college, I was fortunate that one of my colleagues who I had acupuncture from was working at that time in the NHS. And so I was able to, on the back of his kind of recommendation, approach the service manager to see if they wanted any more acupuncturists working for the trust, which they didn't at the time. But I kept nagging them and eventually got a position as kind of an acupuncturist working for the substance misuse team in Northwest Kent. Some of the links with that are quite useful is that we were being employed at band 6. So if you're going to sort of look for work in the NHS, look to peg yourself as band 6 as a minimum, or equivalent, or band 7 is when you're starting to go into the management of people. At the end of my career, I spent 10 years working for substance misuse, and at the end of that period, I was working at band 7 but being paid at band 6. So getting in at that level is quite handy. I found that when I wanted to expand the service within the NHS, the most effective way was approaching the service managers of the individual services. So I approached the pain management service and put essentially a quotation together of, how they can benefit. And the benefits where we were, it was all cost effective. How much money are they going to save? That was the bottom line. How many people can you treat? How much money can you save? The benefits that I was able to kind of present was using a multi-bed model. So working with more than one acupuncturist and more than 2 beds, in a smaller room, so that we could see a high throughput of patients. We also undertook a piece of research that kind of demonstrated the efficacy of acupuncture. So for those of you that are new to practice, it means, audit your practice, put together, how many patients you've treated, what the outcomes have been. If you're going to be using something like MyMop, which is now, you have to register with it now, with the new MyMop organisers, but, being able to go to a commissioning group, to a service manager with evidence of your kind of historical background of efficacy is going to be beneficial. If you're going to, I found that when I started approaching the managers, one of the first questions they ask is, we don't have any policies in place. So we developed a whole set of policies, and I was talking with Hannah earlier today about, I have a complete set of policies, which I'm quite happy to kind of get put up onto the website as a, we'll anonymize them, so that you've got a starting point of policies that you can go into managers and go, look, it works, acupuncture is effective. Here's the policies that, are going to demonstrate that I can practice safely within your service. When I left the NHS, I've been working kind of as many of us have done with patients in pain. And I approached all of the local pain groups, in particular, the National Back Pain Association, the local fibromyalgia groups. And I went and did practical demonstration talks that they just speak awesomely to your abilities. Doing a presentation in a hall or a presentation in somebody's house pre-COVID, or in a group room where you're able to put a couch up and kind of show to people, right, this is the sort of thing that I would be doing with you. Can I have a volunteer, somebody who's in pain? And then at that time, I would also be handing out, then it was the NICE guidelines. So I'd print off the NICE guidelines to be able to give to people, and the research sheets that we've got on the BAcC on back pain, so that people could take the information away with them to kind of go, oh, right, yeah, it's actually something that I can do. The other thing that was of interest to me, kind of Mark alluded to it, is that the dose. I mean, they mentioned dose in the documentation, dose and pain. And I've raised this a few times with people, and I guess for me, this is just a comment on to get you thinking, what does dose mean? When I trained at the London School of Acupuncture, for us, dose was the number of treatments that you gave to somebody. And something that was put to me at one of the conferences many years ago by Professor George Lewis was, what does dose of acupuncture mean when you're working with pain? Is it more needles, in for longer, using adjunctive techniques, using bigger diameter needles? And so I guess as an aside along how you can use these things, it would be encourage you to think about, if somebody's in a lot of pain, do you need to use a large dose of acupuncture, and what does that mean? But there's a lot of work, I think, that's going to be available on the back of this, I'm hoping. But I think as individuals, you're going to need to present yourselves to the PCTs, the primary care trusts, the commissioning groups, and present yourself on the back of the professionalism that you'll represent. So going in with, you know, the research documents, going in with the nice guidelines is going to really help you and get you off to a kind of a starting point of being in there, at least getting in the door. And that's all I've got to say about that.
Thank you very much, Paul. Now I would like to go to John, because actually I know that you may be a bit time dependent, John, are you? So if you'd like to introduce yourself, please.
Yeah, John Wheeler, former secretary, all-round scribe and fixer. And I'm not really quite sure why I'm here. I was asked a lot, I think, mainly because I'm the organisational memory. It goes back a long way. People have questions that allude to things gone way before. I also sit on the Professional Recognition Working Group. And I suppose my interest in this is I'm somewhat older and more cynical than most of you, that I never saw the previous guidelines really help individual practitioners that much. But I do see the possibility that the guidelines will actually help the case for our professional recognition greatly, which in the end is to all our advantages. The chatter I get from contacts with the medical profession is quite a lot of understanding and excitement about the use of acupuncture, but no money. It's a question comes up all the time on their forums. It's great, who's going to pay for it? So I think there are major issues about that, and I think I pointed out the last time we got into discussions about the back pain guidelines, when they were unfortunately removed by a group of spinal injectors who got their own back on us by getting us off where we'd taken their place, is that the recommendations for acupuncture had very little impact on the business of BAcC members. Although if you're an AACP member, you actually did quite well out of it. If you looked at the various appendices, they, because they were inside the tent already, did get what funding was available, but I have to say it wasn't very much. So my view really is that I think we have more to do with making a case for our professionalism and our standards through this than anything else. And I think the thing I've been quite critical of the BAcC in the last few years about is the failure to distinguish clearly between acupuncture, traditional acupuncture, and the BAcC. We tend to use the profession, acupuncture, and things all interchangeably. And I think we need to be very clear in our messaging. This is PSA accredited BAcC members who are the most able to deliver on this. Otherwise, we're basically making a case for anyone that comes in cheapest. And believe me, there are a load of people out there now who would be quite happy to undercut and to do deals to get in. So I think we have to use that to our advantage, the fact that we are the best or the most recognized body that's going. Other than that, I really can't say an awful lot. I'm here mainly to answer questions, so I shall wait. I'm not that time dependent. I've got another Zoom meeting I'm supposed to be at. So if that's more exciting than this, I'll be off. But as I think this is more exciting than that, so I'll stay. So I'm open for questions later on about anything to do with the last 25 years of BAcC history and nice guidelines.
Thank you ever so much, John. That's great. So I now have the very exciting job of introducing Ian, our new research manager, who many of you won't have seen or met before because he's only been here for a very, very short time. Go ahead, Ian.
Oh, thank you very much. I was half expecting a drum roll then.
Lights.
Yeah. So my name's Ian Appleyard. I'm sort of trying to move into Mark's shoes, as it were, in the research department. So I've been at the BAcC for a week now. My background, I actually trained with the person who's next to me on the screen, Paul, some time ago when we were young. And then I went into private practice, and after a period of time, I got a strange thought into my head to go to China. So I went to China and I lived there for about 3.5 years. I taught at a medical school, just English, not medicine, but that gave me contacts, and I was able to go to 2 hospitals in Shanghai and stalk some of their acupuncturists while I was there. And then I gave up my job and I moved to Nanjing for a year, and I was at the Jiangsu, what's it called, Provincial Chinese Medicine Hospital, which is the main one in Nanjing. So I trained there every day for a year and had the pleasure of working with a lot of people who actually were quite old and had taught many of the people who first went to China. So Machocha and Peter Deadman and people like that when the China first opened up. So I managed to catch them before they finally retired, I think. And then I came back and I worked in private practice, and I drifted into education, and I worked at Northern College of Acupuncture, and then down to London South Bank University. I was course director there for a decade, and I got into research. So I did my PhD, which was focused on osteoarthritis of the knee. But a big part of it is how to research acupuncture. And we're just about to be interrupted. I knew this might happen. Good timing.
The beauty of Zoom.
Yeah. So in classic timing. Where was I? Yeah, so I'm particularly interested in methodological problems with research in acupuncture. And I guess I'm keen to try and help acupuncturists membership feel more confident about the research that's out there, because I do believe, and these guidelines are part of it, there is a good news story. And we can push that more. I think we can push that more strongly, and also go for another level of trying to get the nuances of acupuncture put across and get people to take that on board when they're evaluating the evidence. Okay, so I better stop there.
That's excellent.
Yeah.
Thank you. Thank you very much, Ian.
Okay.
So I'll just introduce myself, and then we'll go for questions. I'm the Safe Practice Officer at the BAcC. I know a lot of you are probably very familiar with my face or voice now. I have been a member of the BAcC since 2004, when I graduated from the University of Westminster, and I very quickly began working for a local GP surgery. That was as a result of sending letters and offering to do presentations to GPs. They were happy for me to work there. Things were very different regarding money. They wanted me to work there. They wanted to refer patients to me, pretty much for anything, not just for chronic pain, and they wanted the patients to pay privately. So we came to an agreement where I would charge a reduced amount, because I was being provided with both the referrals and the clinic space. I was working in a GP room. And that was excellent experience. I think you find that if you're willing to offer reduced rate treatments, I know that if things would have changed, and certainly with different budgets nowadays, they would have happily paid for the treatments for the patients, and I think that's where it would have gone eventually. But in the end, I left to move on to different things, and then in slightly later in my career, I wrote to the local council, telling them who I was and what I could do as an acupuncturist. And from the back of that, I was offered to produce a pilot for local drug and alcohol addiction in a homeless centre. So that again started very early on in my career, a very unusual form of treatment, which was group treatments for homeless people, and possibly went some way into why I ended up as a Safe Practice Officer, because it could get a bit hairy at times. And then also later on in my career, I worked for a private company that provided acupuncture, that provided treatments for the NHS, and that was worked on a contractual basis. So I saw somebody earlier asked how to go about arranging payment. This was all done basically via invoice. So the hours were agreed upon with the department. I did 2 full clinic days, and I would get paid on a patient by patient basis. So obviously you are taking a risk there because it is the NHS, and you know there are times where the patient is not paying for treatment, that they don't value the treatment and therefore they don't turn up. However, I must say that that was few and far between, and you would find actually that people were very, very grateful for the treatment that you were giving them. And a lot of that was, I would say 99% of that was chronic pain that sat within back pain and arthritic knee pain, but really any sort of pain was being referred to myself. And that was an extremely, extremely valuable experience. So I think if anybody is willing to approach their local NHS or their local GP or the clinical commissioning group, as Paul was mentioning, and offer their services, you would find it certainly a challenging experience. They're very, very much you may be on the phone to me every 2 minutes talking about safe practice issues, but very, very interesting, very exciting, and well worth the experience. So that is, I'm just looking now. Oh, sorry, I'm just looking. I thought somebody had replied to that. So what I'd like to do is go to any questions that people may have for individuals on the panel. Or if there's anybody that would like to share their experience. I will just ask that, you know, bear in mind that I would like to keep it relevant to the topic we're talking about, and also relevant to a larger audience. So if you can try and keep it as much as that. But anybody with any questions? If you'd like to raise your hand. So Marianne, I can see, if you can electronically raise your hand as well, I find that a touch easier to spot.
Hi, Hannah.
Hello.
Thanks, everybody. Lovely to see lots of familiar faces. I did actually put a few in, in fact, put quite a few in the chat earlier. One of them was, do the guidelines mention anything, because John mentioned about, or either Mark or John mentioned about PCA accreditation, and I just wondered, is it specifically talking about BAcC members, or is it anything in the guidelines about how they're defining acupuncturists? Does it include dry needling? Does it include physios who've done weekend courses? I mean, is it just like the whole gamut of anybody who would like to call themselves an acupuncturist?
Shall I reply to that?
Yes, please, Mark.
Because I did reply in the chat as well, Marion. It does, what it says is that that the acupuncture can be provided either under a traditional Chinese or a Western framework, and somewhere else it does mention dry needling, so that would be part of the Western framework, but the Western framework wouldn't be just dry needling. It doesn't say anything about professional associations, so it doesn't come onto British Acupuncture Council, PSA, or any of that at all. So it's basically they're looking for kind of people who are defined as health professionals and they're acupuncturists, or they're health professionals who do acupuncture, shall we say. But they don't go any further than that, except they don't want them to be paid a massive amount, but a decent amount. Yeah.
Thank you, Mark. Are you any further questions, Marianne?
No, that's fine. I think I can't remember what my previous ones were. Some of them were just comments, actually. But yeah, thanks.
Thank you very much. I can see that Nick has his hand up. Nick Lowe, would you like to take yourself off mute?
Hi, thank you for putting this talk together. Yeah, good thing to organise. Question for the panel, and maybe more particularly the Recognition Working Group. A lot of this has been aimed at the the practitioners taking the bulls by the horn, so to speak, approaching GPs, almost a grassroots movement to try and use these guidelines to connect, which is obviously fantastic. And hopefully they'll give us a lot more oomph in our attempts to do this. I'm just curious to hear if the BAcC and the working group has some more concrete plans and steps. I think Susan briefly mentioned some. What are we doing to approach the clinical commissioning groups at a kind of broader level? How are we going to use this to our advantage on a slightly bigger stage and tackle, getting BAcC members and traditional acupuncture more involved at a higher level? So I'd be interested to hear
Well, we're due to meet in May, so hopefully we can have a discussion around, what we can actually do. I mean, it's so difficult because in all the different nations, there are different ways of contacting people. And, this is one of the things we're doing at the minute. We are waiting for COVID to sort of slow down a little bit so that we can actually get ourselves in front of health ministers, so that we can tell health ministers who we are, so that if we ever had to go back into another lockdown, that we can actually be recognised as the professionals that we are. It's a difficult thing at the moment because, well, it's difficult even if we aren't in COVID, getting ourselves in front of the people that we need to. But it's definitely, we are on a nation by nation level trying to get ourselves in to talk to the directors of AHPs, to the health ministers, and anybody basically that we feel we can get them to listen to us. So we are trying, we're going out there and we're contacting people. And then now that we've got these new nice guidelines, that'll maybe give us another level of people that we can contact and look about, how we can actually use this to our advantage. It's not an easy thing to do, to get people to actually to connect with us when we are trying to get in at that level. So sometimes it's building it up from the ground level can be an easier way. If we've actually got something that we've done, if somebody's got into a pain clinic and they've got, some work that they've done, then we've got something to show on a higher level, so we can build it up that way. But it's, as far as we're concerned with the working group, it is a drip at the moment. And, it's a slow process to get people to pay attention. But we're keeping at it, and we just keep going and we keep going. And if one door closes, we just keep trying to open another one. And, any ideas that people have about, where they think we should be going, we're absolutely open to listen to members as to where they think, this should be targeted. So get in touch.
Thank you. Thank you. And just before I go on to Mel, I'm going to go to you next. I just want to point out that we have a very, very in-depth chronic pain area of our website that I would like to just direct you all to go and have a look at if you haven't already done so. And on there, you'll find a lot of resources. So you'll find letters you can send to the GPs, which Susan was discussing earlier. But you can also find PowerPoint presentations on there, as well as an awful lot of resources you can use regarding research. So those of you that haven't looked, go and have a look on there. And now I'll go over to Mel to ask her question.
Hi, if it's appropriate, it was actually just an idea that occurred to me that I thought might just be helpful to share if it's still relevant. Back in the day when I was doing a lot of work on migraines fell under the category of a neurological illness. And according to, I think it was the NHS Patient Bill of Rights for neurological illness, it was not acceptable for the NHS to withhold funding for patients to receive a NICE guideline recommended treatment. So I kind of mentioned that in case pain is considered a neurological disease, which you could argue yes or no. But if you made that argument, and if that wording was still the case, that might be one way to, I suppose, encourage more strongly funders to fund acupuncture treatment if they saw that it was basically in writing that it is not kind of an acceptable option for them not to fund it. So that may be a non-starter, and Nick made a really good point about, whether we're talking about a grassroots thing or an organizational level, but that, I don't know, if that information is pertinent, it might be useful.
Thank you, Mel. We'll take that on board and see where we can go with that. Talk to Mark and Ian about that in more depth. Do we have any more questions? Or if anybody's asked a question? Oh, Mark, go ahead.
I've got a question. Well, also, I was just going to point out that Mel is doing the next webinar in this series. So, yeah, thank you, Mel.
Thank you, Mel.
Is it next week you're doing it?
Yeah, I believe it's next Thursday at the same time.
Great, yeah. And Mel will tell you all about neurological details then, I'm sure, and everything else. I had a sort of follow-up question to Susan, going back to that Northern Ireland Get Well UK, wasn't it, initiative back in the 2000s, and so the Northern Ireland office kind of bought into it to the extent that they set up that project, and it looked for a minute like they might then roll it out more generally, and it just died a death. So I was wondering whether now was a good time to try and build on that. And
I mean, absolutely, it's never a bad time to build on that. I mean, we had at the end of the project, it was a year-long project. We had 99.9% of the GPs who used the project actually wanted it to carry on. So they were really happy with it. There were two things that happened. One was cost effectiveness. The Northern Ireland office decided to go with a London-based company. Instead of keeping it local, that we could have managed the whole thing ourselves, they used another company, which was Get Well UK, who I don't think are around anymore. And that added so much of the cost, that bumped all the cost up, that made us look as if we weren't really cost effective. And actually we were incredibly cost effective if we hadn't had all their extra charges for this London company to manage it. So that was one of the things that happened. The other thing that happened was we went from, we became a devolved government during that time. And so we went from having a health minister that was Westminster based to having a health minister that was Stormont based. And he promised us the earth and said this was wonderful and he was going to carry on, and then did absolutely nothing with it. And then the problem within the, it was the pharmaceutical side of the government here that was told they needed to save money, and this was one way to save money. And what happened within that, the government structure, was everybody who was involved in that then moved to a different department. So it just got lost. And it was, it was such a shame because it was so effective and the patients really got better. And, we had fantastic stats. We used the MIMOP on that, and we had fantastic statistics. But unfortunately, yeah. And it is time. It would be really good to be able to revive it in some way. And I think, when I'm able to talk to the health minister here, that's one of the things I really want to mention to him. And Peter Hain, who is our patron, I've just recontacted him. He was involved in that because he was the Secretary of State for Northern Ireland at that time. So I met him and I got to stick needles in him, which was great fun. Some people would pay to do that. But he was very supportive of the whole thing. And, it was after that he became a patron of the BAcC. So trying to get his support again is going to be really useful to try and do it. I mean, I don't know how much we can resurrect of, to try and do the whole thing again would be fantastic. And I suppose it's just allowing the government to see that, we did do that in Northern Ireland. Because everybody that is involved now is completely new to who was involved then, apart from me, of course.
Thank you very much, Susan. Now, Ian, you've got your hand raised.
I have got my virtual hand raised. So I'll take that down. I'll work on that later. Yeah, I just wanted to sort of go back on a couple of things people have said. I mean, one was just to point out with why should, you know, can we do this at a top level or can we sort of grassroots? And one thing that's sort of missing within the evidence is what happens long term. And that's why there's been this kind of partial limitation on how people should recommend acupuncture. There's really no evidence to support what actually happens in practice, I think, for a lot of people with chronic pain. And that is that they have a course of treatment, and then it gets a bit spaced out. And then they come back further and further, and maybe sort of come back once a year. And that sort of pattern of practice, because there's kind of a binary thing: you're on your treatment course, off, and then we assess it. And it's not following sort of the normal as many practitioners would do in practice. And in some senses, if we can show that over a long term, it isn't about acupuncture giving 10 treatments at a block, that you might have 10, 12 treatments to begin with, and then somebody has one a month, and then in the future they sort of come back for a burst of 3 or some pattern along those lines. Then across a longer time span, with all the health economics and things like that, it might turn out to be a lot more cost effective than is viewed at the moment. But unfortunately, as I think most people are aware, acupuncture suffers from lack of funding to do research. So I was looking through the trials that were in the review on fibromyalgia, and a lot of them are quite small in many cases, and it's quite a mixed bag of what's been going on. They sort of maybe have 100 patients, but then participants, but then they split it up into 4 groups to doing 4 different things. So I believe that NICE have taken quite a pragmatic approach. I mean, partly because opioids are not working out well for many people, and they sort of need something. But it doesn't mean to say we're sitting on a glorious pile of evidence. And for me, quite ironically, I would say the evidence is probably better for back pain and things like that. But we've been quite lucky, again, because of the German trials. So there's a large trial on neck pain with 3,000 plus people in there, which kind of boosts up the sort of statistical power, if you like, regarding acupuncture. So it makes it more convincing. But I think if we can, sort of what Paul was saying about sort of it's an individual thing, whilst I think the science is there, and certainly in comparison to other potential treatments, acupuncture should be on the cards, basically. But fundamentally, we have to deal with people as well. And if you were to put yourself right at the top of the health system, you might be kind of concerned if you sort of open what you might perceive as opening the floodgates for acupuncture. Because if you go acupuncture for fibromyalgia, then why not osteoarthritis of the knee? Why not lower back pain? Why not more treatment for migraines? Do you see it, rather than this? And before you know it, you've got a big chunk of the British population needing acupuncture treatment. And then you look at sort of 10, 12 treatments and the cost of that. So that there is a human element to it. And I do think we need to try and play on all levels to sort of go to the person and find individuals within hospitals or pain clinics, etc., work with them, and if possible, start to build evidence. So I haven't had a chance really to talk to many people in BAcC and the various committees about it. But hopefully, if you can contact me, if you're interested, I will try and help as best I can. And my personal feeling is if groups of practitioners work together, it might be more effective. As in, you put a case to a GP surgery and say, we can collectively work together, and we'll try from there. Okay.
I think I'd, oh, yeah, John. You're on mute, John.
So I don't know where to press the buttons for these little hands to come up, but it strikes me, and there's a really good opportunity here for the BAcC to provide a pro forma for a sort of n=5 observational study, which people can try and take out and use. I mean, we're talking here the people that are GPs call heart sink patients, the ones who turn up every Monday morning and they want the same thing every time, which is more painkillers or more drugs. And they would be, I'm sure, because I set up a pilot study which never quite got off the ground, keen to see what the effect would be on their long stay patients. I know that Gerard Kite did a study called the Cactus study on this, trying to get rid of the heart sinks. But I'm sure you'd find willing GPs to participate, especially if you flagged it as a national BAcC enterprise to get as much information as possible from, say, 100, 200 practitioners, picking out 5 patients each would give you a kind of a body of not about efficacy, but effectiveness and cost effectiveness, because you might start seeing some results over that time. And people are much happier, in my experience, to play around with being part of something that's a study rather than just saying, give me some work. That sort of just gets lost in the mire. I'd say, by the way, that contacting GPs is a complete waste of time. It's the practice managers you need to get to. They're the ones that organize everything and run everything. If you put it on a GP's desk, it'll go with the other 1,000 pieces of paper that come in every week, especially as the epidemic lessens and all the people turn up again who are currently too frightened to go to surgeries. The practice managers are the ones who are your best route in. But it would be nice if the BAcC could generate some pro formas that people could take on and run with. Because it would have so the advantage of building up a depth of information based on the same protocols or the same general design.
Yeah, no, I agree. I think that's a really good idea. And hopefully if we can do it, different people doing it in different places around the country, so sort of each person doing 5, and you get 50 people doing it, then you begin to get to good numbers. So
well, that's because you can have say, well, we've got 10 groups. Do you want to be part of the 11th or 12th and sort of multiply?
Yeah. Yeah.
So I think Marion has got a hand raised.
Just really following on from what John was saying, when I worked in the GP practice, one of the partners was completely transparent and said that when they made the referrals to me, it was totally so that they could have a holiday from the heart sink patients. So at least for the 6 sessions they were seeing me, they could have a break. So they were completely open about that. But interestingly, you know, we got really good results, even with most of the patients I saw had conditions that were over a year old, some of them over 5 years old, and even within 5-6 treatments, they were getting clinically significant improvements using MIMOPS.
And that's what we found in the study that we did here. You know, the GP who went off and did his acupuncture training, he actually didn't want us in the practice to start with because he thought, oh, it's just going to be, you know, a lot more paperwork for me, and, you know, these patients are going to be coming in and nothing's going to have happened. And he was totally transformed, you know, and went off and did his acupuncture training because he thought it was so valuable, you know, and that in itself just taught us so much about what we have to offer.
Similarly, when I was in Thames Gateway in the trust, we undertook with the 4 acupuncturists that were working at the time, you know, a collaborative piece of research that looked at longer term engagement, you know, what the outcomes were on longer term engagements. So the study that we did, because the acupuncture was available 5 days a week and free at the point of delivery, you know, they were undertaking 21 treatments over 6 months. So, and that data is the data that, you know, collectively, when you start putting it all together with other studies, is the strength that we have, I think, you know. And as you were saying, John, is having some sort of pro forma that practitioners can follow. Well, you know, I don't see, you know, 10,000 people with back pain, but I do see a number of them. And that if my data was put together with, you know, yours, with, you know, Hannah's, with Susan's, then suddenly, you know, Ian's got something that he can actually get his teeth into. And also, I mean, it brings that professional research research mindedness. I'm reminding Marion of texts of words that were taught to us when we were at LSA. You know, being research minded, thinking about, you know, the longer term outcomes of what we're doing, not just, you know, going into practice and earning money, which obviously is part of what we do, but is using the data that we've got collectively somehow, or even whether that's available, you know, as a piece of work that, you know, we've got whatever 36 people here tonight, you know, how many people have you seen with back pain over how long a period? You know, how do you know what that is? What is the most common painful condition that you treat? You know, that questions that you should be able to answer for yourself, because that information is the information that gets you into the practice managers in the GP surgery, gets you into the commissioning groups to be able to argue, well, this is what I'm seeing, and here's the guidelines that are behind it, here's the policies and procedures that we can put in place, here's the research that shows that it works.
I think we also need to be thinking about getting in touch with patient groups as well, as much as anything else. I mean, I'm not an avid TV viewer, but I remember watching a program with Chris von Tullikin, who's one of the BBC's go-to doctors these days, a couple of years back, descending onto a GP practice in Essex with lots of wonderful ideas. He had someone wild swimming, someone else doing meditation, other people walking. And then he sat in on a doctor's surgery with 28 people, and he found himself, in spite of his intentions, prescribing drugs for 27 of them, not because he wanted to, but because that's what the patients demanded. They quite liked things the way they were. So it'd be a mistaken assumption to believe that everyone's desperate to find an alternative to the medications they're on. So I think it's incumbent on us to actually convince the patient groups that acupuncture is a viable alternative and something we should invest time in getting that message to that end. Otherwise, we'll just find ourselves in the same situation as von Tullikin, saying there are lots of other nice things you can do, but the patient saying, no, actually, I'd prefer to have some more drugs, please. It's a sort of comment on the way our society is now set up, for medications are seen as the sole purpose of the GP in many cases.
Yes.
Yeah, I agree with that entirely, John. I think approaching those patient groups is a really good strategy. I think now with this nice endorsement, it gives you a good intro, because we have in the past had campaigns of approaching patient groups, charities, and some of them were quite fruitful, and some of them you got beaten back. You know, I know we got short shrift from the what's the big heart one. They just said we don't believe there's the evidence for this. But now there are quite a lot of possible groups in respect of chronic pain that you could approach and say, you know, look, this is NICE recommends it now. So, and I think we have approached some already in terms of publicity for the webinar we had last week, and some of those were certainly quite receptive to the idea.
My GP didn't want acupuncturist, but he wanted me to do qigong outside in all weathers, to do qigong with the patients.
Did you do it?
No.
So I see anybody else with their hand up. I see that Rachel has put a question on the chat. Rachel, did you want to take yourself off mute and actually ask the question, and perhaps the panel can answer for you? Perhaps.
She's saying she's got no camera or audio on and on.
Oh, right, fair enough. Okay, well, I'll read it out, and then I'll be Rachel. So she sees many patients who've been prescribed opioids for pain for far longer than the 12-week limit, and many are keen to stop. So she's wondering whether we can position ourselves as an option or an alternative at that medication review stage. Would this be the GP or the pharmacist, I assume, to approach? She tends to send patients back to the GP for a review. In the Welsh audit, we showed many people reduce their use of opioids during acupuncture treatment. So would any of the panel like to go with that, or shall I? Ian? You're on mute.
Yeah, I know. I got. I think not necessarily been too au fait with the workings of GP surgeries, but what I understand that, yeah, the reduction of drugs cost is a very important thing that they'll be looking at, not just on sort of patient care, but on their sort of financial bottom line as well. It's quite important. Just thinking back to when I was at Southbank, we had a small research group that was going, and a couple of the people that came along to that were doing acupuncture within a GP practice. And one of the things that had impressed them was how much they'd been able to reduce their prescribing. And I think globally we have to, because this is a cost benefit of having acupuncture. It's not just about how much it costs to have acupuncture, it's about how much you can save. So it's critical. So within, you know, John's suggestion about looking at 5 patients, but we also want to try and include within that some estimation of if there's any reduction in medication. I think it's absolutely critically important.
Mm. And I think I could add as well that with Rachel's question, she's asking as well whether to talk to the GP or the pharmacist. And I think if you're finding that this is happening a lot, Rachel, I think perhaps get yourself a template letter that you can send along with the patient back to their GP, and that can, you know, include a lot of what Ian has been discussing, and the chronic pain resources that we have, as well as informing the GP of the NICE guidelines. And it may be that approaching from that actual patient level is a good start. And certainly if a GP has 4 or 5 patients do this, then that will be something that will really start to be flagged up in their mind. So that would be my particular advice in that respect, is approach the GP with a letter from yourself. Also perhaps offering to have a discussion with them, to give a PowerPoint presentation, one of, you know, either the one we have online, or one of your own. But that's where I would go with it. Alan.
Grand. Hiya. So the question that I had when I was reading through the NICE guidelines, much more on the pedestrian side, not the usual outside of the box thinking, was just the interpretation of the phrasing up to 5 hours of practitioner time. Now, is 5 hours of practitioner time 5 sessions of 60-minute treatments? Or is it the amount of one-to-one time that a practitioner might spend? So, for example, I've both done 75-minute one-to-one treatments, but I've also done 20-minute spacings in multi-beds. So would 5 hours of time be 4 sessions, or could it be 15?
Mark, do you have you're on mute.
Sorry, I was just typing a reply to Rachel at that point. Yeah, Alan, could you just say that again briefly?
Yeah, no, sure, not a problem. 5 hours of practitioner time.
Yeah.
Specific to just the one-to-one portion, or could it, if you're operating, for example, a multi-bed setting where you're seeing patients every 15, 20, 30 minutes apart, the interpretation of how we define 5 hours of practitioner time in the NICE guideline.
Yeah, I think that is an issue, and we did, and other people as well commented on, why don't you have a look at multi-bed setups, because it's going to entirely change the whole cost effectiveness situation. So as it stands, they're just thinking down the lines of one-to-one treatment, and
right.
But I know that the BMAS, British Medical Acupuncture Society, for example, made a comment about the I said, because they had a multi-bed one for osteoarthritis, where there were massive cost savings for the NHS with that. So they were talking about whether things like that can be offered, and so NICE doesn't really spell it out. So I think it would be a question of negotiating that locally with local commissioners.
Yeah, just to add, I think they didn't have an awful lot of evidence to base the costing on. They only had 2 trials to sort of do the sums with, one of which was in Germany. And they thought that it was potentially underestimating the cost. So they've sort of done, I think, a sort of bit of reverse engineering, kind of knowing how much can we get for a certain amount of money, and is that still cost effective? So that's why they've set it. They haven't really, so what I was trying to say before is it's not really based on how you might treat, like 6 treatments and then a few and then a few to get more longer term benefit. So my guess is, in their heart of hearts, they thought, we've sort of bent it a little bit already. If we go off and say, oh, can it be even cheaper if this is on a multi-bed setting, then the people who are particularly hostile to acupuncture would have a field day with them, saying you're just making it up because you don't have any evidence of how much it costs to treat people with primary chronic care, because you've only got 2 trials anyway, both on neck pain, one in Germany, one in the UK. So they might have felt they were trying to stretch it a little bit by putting in that kind of cost analysis. That's a guess. I obviously don't know their actual thinking on it, or maybe no one has told them about that.
They have added they have got a research recommendation as well, which is because as well as the endorsements and stuff, they also at the end stick in a bunch of things that we might want to research, and one of them is the effectiveness and cost effectiveness of if you had a repeat course of acupuncture.
I suppose there's the written detail of the NICE guidelines, but there's also, there is the precedent of acupuncture provision on the NHS currently. So, for example, at my local hospital, there's a centre of 10 physiotherapists, 10 AACP members operating an acupuncture for chronic pain service. And I mean, they're not one-to-one. They do essentially a multi-bed model, and it strikes me that in pain centres, that seems to be a bit of a norm.
Yeah, no, I think it's really what they looked at from their sort of system. They've set themselves up to look at this evidence. They've done the search, and then they've kind of restricted themselves to that, because to step outside of it, which for a lot of people would just be logical, it kind of would be perceived as being unscientific. It's sort of like you're doing a post hoc, trying to bend things as you wish them to be. So, my guess.
Sure, that makes sense.
My feeling, Alan, would be if they've identified 5 hours, then there might be a number of different models that could be used, and the multi-bed is one of them, to demonstrate the efficacy of the different approaches. So 1-to-1 of 20 treatments with a multi-bed model, or 15 treatments, is that more or less effective than 1-to-1s with 1 hour treatment times? I mean, like you, I think the multi-bed, these guidelines, I think, could be used to support a multi-bed model, because it is more cost effective using a multi-bed model. So I think that if a primary care group or a commissioning service or a practice manager is trying to save money, then going in with that as a model to work to, I think is going to be able to demonstrate greater cost savings. I appreciate, Ian, that there might not be the research out there yet, but that's kind of my kind of comment to everybody on here, is really research starts at home. you know, start building up, you know, individual case histories of your own that can then support larger pieces of work. You're on mute, John.
I know I am. The point worth making there, Paul, this goes back a long way into the history of the BAcC, when people were being paid 4 hours for a session by a local practice, and they expected to see 16 people. And the argument always was that it only took 1 or 2 BAcC members to drive the unit cost down by taking on work at farcically low levels, and everyone else suffered as a consequence, because word went around you could get acupuncture for 10 quid or 15 quid. It has to be done with great care to make sure that those people that really either don't want or can't afford to start offering treatment at well below market rates don't get squeezed out of the system because you end up accidentally promoting something on a multi-bed level. I think what they've done probably is they've specified the level of band 7. That's got a salary scale. I think they probably work backwards. I think Ian's right. They probably set a target, looked at the band 7 costs, and then divided that back in. That's 5 hours will be the amount of money they've decided. And I think how you want to cut it up after that is up to you. And I think it's something that BAcC needs to approach with a little bit of caution, in case the multi-beds get in successfully and establish that the only model that can be funded is a multi-bed model. Would be tricky if someone really had to work at 45 or 50 quid a session, because that's how they worked. To be honest, I think sometimes this is a kind of what color wheels on my Bentley type of discussion, because at the moment no one's got anything out of the nice guidelines. So I won't get too carried away with the technicalities until some people start actually getting some referrals. Oddly enough, on my FB site, one of the members there got a referral not through the GPs, but because of the publicity around NICE within 2 hours of the guidelines being released. So there may be other ways people benefit. I've just said this is a caution. We had this before, where one member was seeing 16 people in 4-hour session, and it put everyone else's noses well out of joint. Mark, when you're there,
when I'm there,
well, you're there.
Yeah.
The last time we became recommended for back pain guidelines, the people we sort of ousted were the spinal injectors, who really took umbrage and actually managed to chair the committee and also load it with their own people and fight back. What you've read in the sort of the large chunk of documentation at the end, do you get a sense that the pharmaceutical industry and the pharmacologists are going to fight their way back to try and beat acupuncture off at the next review, which will be what, 4 or 5 years time?
I don't get a sense that there's anything like that hostility that there was with the back pain guidance. The pharmaceutical industry, in their comments back in the draft guideline, seem to be saying, to some degree, we think it's a fair cop, but you've gone too far. I think that tends to be their point. I haven't seen anything where they said this is ludicrous. Paracetamol is a much better bet than acupuncture, for example.
I mean, the cost is so little that it really is immaterial whether they're having. Yeah.
Just on spinal injectors, I've got a patient who she's been on tramadol for years and years and years. Okay, she has acupuncture every week, but the only thing that's really sorted out the severe back pain is that spinal zapping the nerve roots. Yeah, she wants everything basically. She says acupuncture is the only thing that gives her relief, but it only does it for like a week, and then she comes back and gets some more.
Right, well, thank you very much. I don't know, is there anybody else that would like to ask a question, or is there anybody on the panel feel that they have something else? Ian, is your hand up because of it was up?
Yeah, it is still up. I was just going to chip in a little bit about the guidelines, just to make people aware, because when they came out, I did my cursory look at what the skeptics are saying on their websites. And of course, they tend to lead with, they take out extracts from the guidelines that says low evidence or low quality evidence, blah, 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 and say, well, how can you make any judgments for acupuncture because the evidence quality is so low, poor, poor, poor. The reality is it's poor for absolutely everything. when you go and look at the other appendices, I mean, the only thing is that will get a high quality thumbs up is some of the drug trials, because they can be double blinded. But there's quite a lot of drug trials that still come through as being poor to low quality evidence. And certainly for the exercise and the talking therapies, it's also not coming through as good evidence, because as soon as you don't double blind it, that takes it down a notch. I think you can't be any better than moderate once it's not double blinded. So there are some acupuncture trials that count as moderate. And I didn't find one for, I think it was I had to do a few searches, but in the others, either the talking therapies or the exercise have absolutely no moderate quality trials. So if people come back at you and say, well, the evidence isn't very good, well, it isn't very good for anything in BAcC, and it's just kind of a judgment of the process. It doesn't mean that it doesn't work, sort of thing. So,
thank you very much. Thank you, Ian. So I think that's all the questions, and I'm going to wrap it up now. Then, if everybody's asked everything, there's been some excellent comments on the chat, so I encourage people to have a look on there, and particularly comments rather than questions. And just thank you all for attending today. Thank you for our wonderful panel, especially Mark, who's no longer employed at the BAcC, but a fantastic resource for us. So also thank you Susan, Paul, Ian and John for being here today. Jen is clapping, I think. And so thank you very much, and thank you for Jen to be there in the background, who's been helping things along. So I'm going to end the meeting now, but we will have this meeting available on the IE News at some point in the near future. So we should take care, and we shall see you all again hopefully next week at the next chronic pain webinar. Thank you. Take care. Bye bye.
Thank you. Bye.